to our presentation on Accountable Care Organizations, ACOs. My name is Jeff Squire, and I am the Executive Director of NEWHVN. As you may know, NEWHVN is a clinically integrated network of 650 physicians, Bell and Health and Theta Care. Recent changes and new developments in regard to payment reform and healthcare delivery models will have a significant impact on healthcare providers. Our presentation today discusses how these new models will work. Accountable Care Organizations, or ACOs, shifting gears. With the passage of the Patient Protection and Affordable Care Act, a new set of rules, regulations, and changes were initiated. Not only does the legislation require health coverage and reform insurance regulations, it also sets into motion health payment and delivery reform. Section 1899 of health reform legislation establishes Medicare's Shared Savings Program. This section of the legislation uses Accountable Care Organizations, ACOs, as a governance tool to facilitate reform. Not only are government payers backing the formation of ACOs, but private, non-government payers are embracing this idea as a way to incent change. By definition, an ACO assumes accountability and some level of risk for cost and quality of care for a defined population. The level of risk is determined by the healthcare provider. This change will alter our traditional fee-for-service reimbursement revenue process. Why now, and what has changed? The recession and a return to uncontrolled overall healthcare costs fuel the belief that the current system fee-for-service payment model incents only a quantity-driven payment methodology, but does not incent or reward healthcare providers for efficiency or quality. Lastly, passage of healthcare reform creates the legal opportunity to address changes to how care is delivered and paid for in the healthcare industry. Today, we have the ability to collect, aggregate, and move healthcare information not realized in the 1990s. We also know that reform must be provider-led, not payer-led. The rapid increase in healthcare costs, as demonstrated in our per capita costs being twice that of other developed nations, demonstrates our existing path is unsustainable. This cost difference drives the belief amongst employers that our competitive global position is undermined by the cost of healthcare. And as healthcare expenditures consume a larger portion of our nation's gross domestic product, our ability to invest in our country's future, new technology, or economic growth is restrained. Recent reports state that healthcare-related expenditures are now more than 17.5% of GDP. We spend more on healthcare, but do we get additional value and improved performance in return for investment in healthcare? This report, Mortality Amenable to Healthcare, funded by the Commonwealth Fund, suggests our health system's performance does not provide the value we expected. Many factors contribute to this, but it clearly demonstrates we do need to change our present course. The health of our community is not being maximized. Moving from our existing payment and delivery model will require a dramatic shift in how we operate our clinics and hospitals. The current payment cycle creates a focus on volume. As long as we code, document, and bill for the service under the rules established by the payer, we receive payment for the service provided. The new payment model will incent payment for not only providing the service, but demonstrating the service enhances value to the patient. This value statement is based upon adhering to protocols and guidelines that demonstrate effective outcomes and high quality. The value-based model emphasizes that high-quality outcomes are less expensive than suboptimal outcomes because we lower the likelihood of rework and eliminate potentially avoidable complications to care. Payment is not only based on providing the service, but incentives for performance are included as a payment bonus. To be successful in this new era of accountability, we need to transform the way we think about healthcare events. As demonstrated in this slide, an admission to the hospital was thought of as an opportunity to provide care. It was also how we funded our healthcare system. Under the ACO model, we will need to examine if the event could have been avoided. Payment will be tied to preventing potentially avoidable complications from occurring. New methods to manage and coordinate care will need to be developed. Information will be critical to understanding how specific patient populations access, use, or misuse the healthcare system. Perfecting the communication and patient handoff process is critical to coordinating care for complex patients. In the early stages of ACO formation, we have the ability to influence and decide how ACOs develop. The spectrum of risk-taking goes from one extreme, full capitation, to the other extreme of transparency-only programs like the Wisconsin Collaborative on Healthcare Quality. As the discussion about ACOs moves forward, we need to make a conscious decision on how accountable and the levels of risk we are willing to assume. Under existing NEWHVN agreements, we have pay-per-performance and outcomes-based incentives in place. Will this suffice, or will the market require a greater level of integration and performance? As demonstrated in this slide, there are some provider networks and organizations whom are ready and willing to accept full capitation. Other groups may not be ready for that much change. It will be prudent for us to examine all options, but ensure the pilot projects and programs we decide to investigate or pursue match our willingness to accept risk and accountability. Even though the ACO concept may be new, many organizations throughout the nation have been working in the spirit of an ACO. These provider organizations listed on this slide have had the vision to engage payers and develop new creative methods to encourage higher performance and better outcomes and be rewarded for these efforts. The first organization listed, Advocate Healthcare, has agreed to a global budget with Blue Cross Blue Shield of Illinois. If Advocate achieves superior outcomes and controls overall costs, Blue Cross Blue Shield of Illinois will pay the providers a bonus. If cost and quality goals are not met, the providers in the Advocate network receive a lower inflationary increase in future years. Another example on this page is Piedmont Physicians. Piedmont Physician Group has an agreement with Cigna Healthcare that allows for Cigna to help fund and support care coordination efforts at Piedmont clinics. The idea is the enhanced care coordination efforts will lead to better performance and lower costs that both Cigna and Piedmont physicians will share. Lastly, I have listed NEWHVN on this slide. The energy and effort all of us have invested in NEWHVN have changed the relationship we have with payers in our market. They are beginning to realize the value of clinical integration and superior results. As the ACO concept and structure begins to reveal itself, what do payers in our service area think? I've had the opportunity to speak with the payers in our market. They, be it commercial or government payers, are open to discussing with NEWHVN different quality and payment incentive options. As this slide demonstrates, the top half shows government payers. CMS has many options at its disposal. The Wisconsin Payment Reform Initiative is a consortium of Wisconsin-based providers, health systems, and payers investigating alternative payment methods that align the patient, provider, and payer care processes. This group is looking to develop a multi-payer platform to test new payment models with health care providers in Wisconsin. On the bottom half of this slide are individual initiatives that payers have come and talked with us about. Please note, these are only in the discussion phase. It is a positive sign that the payers are seeking us out to have these discussions, but we have not yet agreed to implement any new models with the payers. We're only engaging each other to see if our ideas are practical and provide a strong opportunity for learning and success. The change from our existing payment and delivery system to a new system based on performance and outcomes will take a coordinated, organized effort. Challenges will include data collection, new care management processes, and a strong infrastructure to support this process. We will need to engage primary care services from a holistic view, a focus not only on treating an individual, but also on demonstrating improved outcomes for the community we serve. Though all these issues will be a challenge, but achievable, none of them will be truly successful unless our physician community is engaged in leading this process. Past history with failed care initiatives and programs demonstrate it is critical to have physician leadership. Ensuring physicians have a voice in this process and lead and direct the care management changes is instrumental to future success. Thank you for your time and attention. The changes coming in our healthcare market will be dramatic. As we have discussed, accountable care organizations, ACOs, assume a level of risk and accountability for better care, improved performance, and controlling healthcare costs. This process is evolving, and we, the healthcare providers, can have a significant impact on what an ACO becomes. At New Haven, we will continue to learn and explore our options. We will also provide you with more information and details about this process as we move forward. We ask you, as a healthcare provider, to continue to learn about the health reform initiatives. Many of the medical societies offer an opportunity to educate their members. Also, speak with your colleagues. They will have valuable insights and knowledge about ACOs.